This online section is being presented to you by AMS University out of Tempe, Arizona. It includes new material published in the National EMS Education Standards in 2009 in response to the EMS Education Agenda for the Future. My name is Wendy Younger. I'm a paramedic educator for EMS University, and I will be presenting this program for you on immunology. We went over quite a bit of this information in the infectious disease section, including the pathogenic agents that you're normally exposed to, and also talking about the external barriers to infectious diseases. However, this section is more on internal responses that the body makes and internal defenses against infectious diseases and harmful pathogens. Now, the immune system responses are normally protective, but they can be overly sensitive and directed at harmless antigens, which lead to allergic reactions. That we'll be covering a little bit later on. Now, the healthy body reacts to antigen challenge through a collective defense system. This system is called immunity, and it can be from a number of different sources. Natural immunity is present at birth. It comes from mom and dad. Acquired immunity develops through exposure to specific antigens or pathogens. Now, if organisms penetrate the body's external defense system and are able to get into the body, the internal defenses act to try and slow down or kill that particular pathogen. Those defenses are categorized as natural immunity or acquired immunity. And the efforts of both types of that immunity is regulated by protein hormones. They're called cytokines, and they mediate natural immunity, including tumor necrosis factor, interleukin 1 and 6, and chemokines. Cytokines that mediate acquired immunity include interleukin 2 and 4 and transforming growth factor. Now, natural immunity is sometimes called nonspecific immunity because its mechanisms don't try to identify the specific invading organisms. It provides universal defense against pathogens that get through the external barriers. Inflammation is one of the most familiar forms of natural immunity. The inflammatory response involves the movement of agents to a particular area or changes in an area's properties to help fight infection or to heal injuries. Triggers for the inflammatory response can be infection, caused by maybe a bacterial invasion, or injury, such as a chemical burn or injury to a joint. The inflammatory response starts when a cell is injured. When a cell is injured, it begins to have trouble maintaining its cellular membrane, and it also loses the ability to control its metabolism. This causes the cell membrane to begin to leak, and the cell itself begins to be consumed by its own enzymes. Arteries and veins or small vessels in the area rush blood to that area. This is a vascular response to the injury. That change in permeability produces edema. The initial cell injury and changes in not only the permeability of it trigger various agents and systems that fight infection and clear the destroyed tissue. Phagocytes, start doing phagocytosis. It's performed by what they call the phagocyte system. It consists of mobile cells formed from stem cells in the bone marrow. In the marrow, they develop into monoblasts and are released into the blood. The monoblasts, once they get into the blood, are called monocytes. Monocytes eventually settle into tissue and mature into macrophages. Macrophages basically absorb foreign material like cellular debris, and they kill foreign microbes using enzymes and other materials, and they slow the spread of infection. They have a lot of other specific names. Some are simply synonyms like histiocytes and things like that, and others refer to the tissue in which they eventually reside. In the central nervous system, they're called microglia. In the liver, they're called Kupffer cells. In the lungs, they're alveolar macrophages, and in the bone, they're called osteoclasts. Although they're general defensive cells that fight anything that is recognized by them as non-self, or basically just debris, their effects can also be amplified when a specific foreign material is identified through the immune system. Other cells that perform phagocytosis in a similar fashion are macrophages. Now, granulocytes are white blood cells, and they have a really important role in inflammation and natural immunity, and there's three separate types. There's neutrophils, eosinophils, and basophils. Neutrophils form the major cell population in the inflammatory response. They non-specifically consume foreign antigens and debris, but they can be amplified during an acquired immunity process. Eosinophils are white blood cells that respond generally to inflammation, but they're thought to be most active against different classes of pathogens. They're particularly effective at destroying parasites, and whenever you have a patient that has a high level of eosinophils in their bloodstream, it indicates that there's an infection in their body, generally with a parasite. Now, basophils are also white cells with some functional differences. They enter the inflammatory sites and mediate responses to foreign agents or materials. Their actions are pretty similar to mast cells. Now, the lymphatic system plays a large part in the immune process too. Okay, it includes the tonsils, the thymus, the spleen. All of those help clear infected material from the body and provide additional immunity. It also contains lymph tissue, lymph fluid, and it flows away from body tissue toward the heart, in the process removing cellular debris and pathogens from the tissue. Now, lymph is clear and colorless, except where it drains from the small intestine, and there it's kind of opaque, and it comes from material that's drained from the intestinal circulation. Lymph passes through lymph nodes. Lymph nodes kind of act as a filter which removes foreign materials and collects infection-citing cells that kill pathogen on its way to the heart. The lymphatic system generally mirrors the venous and arterial circulation. Lymph capillaries start in the tissue and they gradually merge together to form larger vessels called ducts. The lymph capillaries are spread throughout most of the body. The only place that there is no lymph drainage is in the central nervous system. Also, there is none in the bone marrow or tissues that don't have a blood supply. The lymph drainage eventually feeds into the right lymphatic duct, or the thoracic duct. These ducts feed back into the central veins that enter the heart. And although the circulation is kind of similar to blood circulation, it's different in a couple of different ways. Lymph carries this cellular debris and other material away from the tissue, whereas blood carries it to and from the tissue. Lymph tissue doesn't circulate back and forth between the heart and the tissue as blood does, but instead it follows this one-way path from the tissue to the heart. Lymph capillaries contain one-way valves that prevent the movement of that debris and the infective stuff back into the tissue. Lymph vessels also contain these filtration structures known as lymph nodes, and they filter out the debris and antigens and whatever from the lymph as it passes through them. Lymph nodes contain these high concentrations of lymphocytes and macrophages, which destroy the pathogens. The major groups of lymph nodes are located in the groin, the axillary nodes, and the cervical nodes. When an infection is present in the body, those nodes often fill up with foreign debris, causing the lymph nodes to enlarge. Finally, they contain cells known as lymphocytes. Most lymphocytes are a key part of the acquired immunity system, but one type of lymphocyte, called the natural killer cells, is the best example of natural immunity cells in the body. They destroy many, but not all pathogens, and they're not specifically configured for certain targets, and so they're basically non-specific killers. They do not destroy normal tissue, so their action isn't random, but part of an intentional immune response. Acquired immunity is broken down into two types, humoral and cell-mediated. Now, both of these require previous exposure to antigens, and they take some time to work. Acquired immunity is basically the process by which the body recognizes non-self and mounts a specific defense against them. An acquired immunity can be thought of as an enhancement to the inflammatory response. Acquired immunity offers two more specialized features beyond the basic inflammatory response. First, it builds memory for certain antigens so that encounters with the same antigen prompt increasingly powerful and effective defense responses. Second, it amplifies the effect of natural immunity, acting on cells like macrophages, neutrophils, and basophils to make them more effective against certain recognized targets. Acquired immunity accomplishes these things through the actions of lymphocytes, known as B and T lymphocytes. They identify specific antigen and respond in one of two ways. Humoral immunity. B lymphocytes respond to antigens by producing antibodies, which destroy bacteria. This is known as humoral immunity. It's primarily used to kill bacteria that are moving through the body's tissue and fluids, and thus can be found and killed by mobile antibodies. It also triggers mast cells and the complement cascade. Mast cells act like basophils, but the basophils circulate. Mast cells don't. They're found inside tissue, and they come from different origins. The complement cascade is a series of proteins that interact with each other in a fairly structured manner to destroy pathogens. Now, for cell-mediated immunity is associated with the formation of a group of lymphocytes that attack and destroy foreign material. Pathogens that are found inside body cells or trapped in the macrophages are killed by these T lymphocytes. Whenever there is a macrophage-trapped pathogen, the T lymphocyte activates the macrophage, allowing it to kill the pathogen. In the case of like viral infections, the T lymphocytes directly destroy the body cell to kill that indwelling pathogen. Both of those, humoral and cell-mediated immunity, are really effective mechanisms for fighting infection, and they play a huge role in almost all physiologic actions of the immune system. The process by which they're activated is known as the phases of immune response. In terms of the phases of immune response, the body first has to recognize that an antigen is present. This is known as the cognitive phase. In this phase, antigens bind to specific receptors on lymphocytes that are unique to that particular antigen. When that receptor is bound, the lymphocyte knows that this particular antigen is present in the body. The process by which the lymphocyte activates other lymphocytes is known as the activation phase. What happens there is the lymphocyte specific to the identified antigen begins to duplicate. It leads to increased numbers of clones of the lymphocyte specific to that antigen. This process is called amplification. The lymphocytes themselves can also change during the phase, converting from antigen-recognizing cells to antibody-secreting cells. The same cells basically convert from an intelligence-gathering cell, to a killing cell. This is known as lymphocyte migration. Through amplification and lymphocyte movement, the body needs to maintain only a small number of those passive surveillance cells that are attuned to that particular antigen. But if it's discovered, it can quickly form into an entire army of cells dedicated to the task of killing off the antigen. The process of getting rid of those is called the effector phase. Cells that operate during the effector phase are called effector cells, and they include activated lymphocytes and inflammatory components of immunity, such as cytokines, basophils, mast cells, and macrophages. Now, there are a number of factors that affect external defenses. Okay? The external defenses in the human body can be amplified by other means. The skin is an outstanding natural barrier to infection, but PPE is even better at preventing exposure. This equipment supplements the skin in places where it may not be intact. It prevents that invasion by antigens that can erode or bypass the skin and can cover the body in places where the skin is not present, for example in the mouth. In other cases, rather than prevent entry, exposure of healthy individuals to pathogens exiting in an already invaded host have to be prevented. And this can range in scale from surgical masks on a patient with tuberculosis to large-scale public health interventions, such as quarantining a neighborhood. Many things can detract from the ability of the body's external defenses to operate properly, especially when skin is open or burned. Cough reflexes can be blunted by medication. Natural flora can be eradicated as a side effect of antibiotics given for other indications. Many different sources can change the pH of urine and the stomach. Tonsils can be surgically removed. Smoking can destroy the little cilia in the bronchus that trap particulate matter. And diet and medications can slow down intestinal motility. Now, there are things that affect internal defenses. Okay? Antibodies are given to a patient. Just as B lymphocytes can secrete antibodies designed to kill a certain pathogen, antibodies can be given to a patient as a medication. These kind of antibodies are called immunoglobulins. For example, you might give a patient a tetanus shot or hepatitis B immunoglobulin. The administration of those kind of things confers passive immunity, which means the patient is immune as long as the antibodies are active in the body and they're present in high enough numbers to protect themselves. Now, active immunity can also be induced. Patients are exposed to a synthetic dead or modified pathogen in amounts that wouldn't cause an infection. Okay, the pathogen can't hurt them, but it induces the same immune response as a true pathogen. And though through the mechanisms of acquired immunity, the patient then has an apparatus needed to fight that pathogen off if they were ever exposed to that actual antigen. Vaccinations, okay, are the best example of that kind of induced active immunity. Vaccinations that are currently required or recommended in the U.S. population include those against pertussis, diphtheria, measles, mumps, chickenpox, and rubella. These are all administered in childhood, and some of them may require boosters to maintain a certain level in the body. Vaccinations can be really important for certain high-risk populations, such as children and the elderly. Both populations have decreased mortality rates from infections that are now prevented by vaccinations. Flu shots are developed each fall to fight the strains of flu that are expected to be most prevalent that season. The CDC, they publish recommendations each year regarding flu vaccines based on supply and demand. In general, inactivated flu vaccinations during certain periods of the season are reserved for high-risk populations. Attenuated vaccines can be given to any non-allergic, non-pregnant patient aged between 5 and 50 at any time. Because vaccinations depend on an adequate immune response, the response might be variable in patients who are immunocompromised or of a different age extreme. A high-risk population is a group at increased risk for infection. Some individuals are at high risk because of their occupation. Healthcare workers, even the healthy ones, are considered a high-risk population because you're frequently exposed to all the new and improved pathogens. Others that are considered high risk are patients that live in high concentrations of the population. There's also areas where pathogens are present in these in high frequencies. They consider those pandemic areas. Patients who have impaired immune systems, absent immune system components. For example, people who've had their spleen removed or their tonsils, and reduced efficiency of the immune system. They're very young and they're very old. Identifying and protecting individuals who might be at high risk is an important public health mission. Now, hypersensitivity represents a pathologic response where the body's re-exposed to an antigen. The response is pathologic because instead of functioning to harm a foreign material, the body either attacks its own cells or mounts an inappropriately large response to foreign antigens that cause no harm. Hypersensitive disorders are divided into 4 types: immediate, cytotoxic, immune complex mediated, and T-cell mediated. Immediate hypersensitivity is the most familiar of those, and the mildest form is an allergic reaction. Some patients have a predisposition toward allergic responses when the body is exposed to an antigen to which it's already developed antibodies, and those antibodies overreact to the exposure. In immediate hypersensitivity reactions, the antibodies involved are known as IgE antibodies. They're produced during the initial exposure to an antigen, and they're stored, bound to those basophils and mast cells. When the antigen appears again, the IgE antibodies recognize it, and they trigger a massive release of histamines. Histamines dilate capillaries, cause vessels to become more permeable, causing flushing, edema, and potentially the loss of intravascular volume as the fluid leaks out into the tissue. Hypotension and cardiac failure can result. Histamine also causes the itchiness seen in allergic reactions. Leukotrienes are also released and cause bronchoconstriction, resulting in coughing, sneezing, wheezing, and potentially respiratory arrest. The cascade can cause, that's begun by activating of the basophils and mast cells, also can cause nausea, projectile vomiting, uncontrollable diarrhea, and abdominal pain and cramping. Secondary effects from primary hypoxia or even shock can be seen in a lot of systems, such as the nervous system, including confusion, weakness, headache, seizures, and ultimately possible coma. In its mildest form, an allergic reaction manifests itself with itchiness and hives and urticaria caused by that release of histamine. The patient may also complain of flushing, warmth, and tingling. Pre-hospital treatment consists of intravascular IM administration of antihistamines, such as Benadryl. Local measures at the site of the exposure, if external, include dependent positioning of an extremity and an application of ice if it's not otherwise contraindicated. Now, moderate allergic actions can have respiratory involvement, such as mild wheezing and mild complaints of difficulty breathing. usually perfusion isn't effective. It's probably not going to be life-threatening, and we generally respond well to the administration of an antihistamine, but they obviously should be closely monitored. Anaphylaxis represents the most serious manifestation of immediate hypersensitivity and causes up to 1,500 deaths a year. It's characterized by respiratory failure, hypotension, cardiovascular collapse, multi-system involvement, and it happens very quickly. The hallmarks of anaphylaxis is cardiovascular collapse. It can occur without even respiratory symptoms. Death from hypoxia or cardiovascular failure can be rapid. Any patient who has a history of having immediate hypersensitivity reaction is at risk for an anaphylactic reaction at some time. At the first sign of anaphylaxis, administer epi. If the patient is unstable, administration of intramuscular 1 to 1,000 epi is indicated. The reason for intramuscular instead of sub-Q is if they become vasoconstricted, the 1 to 1,000 is going to be slower to work than if you get it into a muscle which has a better blood supply. If they're hemodynamically unstable, evidenced by cardiovascular collapse or really low blood pressure, administration of 1 to 10,000 may be ordered. The reason for the use of the epi in allergic reactions, there's three specific good things that it does. Unlike Benadryl, which only blocks H1 receptors, epi reduces the release of those vasoactive amines from mast cells and basophils. The alpha effects cause vasoconstriction, which raises the blood pressure, and the beta effects cause bronchodilation. So the release of those vasoactive amines is decreased, and the effect of those already circulating are reversed. Also administer Benadryl, diphenhydramine, IBRIN. Airway, breathing, circulation are going to take priority in assessment and treatment, but airway management in these patients is critical. Anaphylaxis becomes an airway emergency in healthy, non-traumatized patients. Consider any complaint of tightness in the throat or shortness of breath as showing the high potential for respiratory failure. Administer high concentration O2, monitor pulse oximetry and capnography, get a line started, and administer fluids as appropriate to keep their hemodynamic status going well. Patients who have cardiovascular collapse as a result of vasodilation may need large amounts of fluid to correct the hypertension. Closely monitor these patients for development of pulmonary edema because the vessels surrounding the alveoli dilate and become leaky along with the rest of the vascular system. Once you have ensured their cardiac and their respiratory stability, all interventions for less severe allergic reactions should also be used for anaphylaxis. Aerosolized epi can be given if available, and if they have respiratory symptoms. Anything that's still in contact with the patient that caused this reaction should be removed. Glucagon may be ordered by med direction if a patient's taking beta blocker. Also, beta agonists such as albuterol can be helpful for bronchospasm that's refractory to epi. Steroids such as solumedrol are available to paramedics in some systems. Those meds don't immediately relieve the signs and symptoms, but they do reduce the inflammation that's associated with them. Because steroids exert their effects through their anti-inflammatory actions, their onset is slow, and they should be administered after medications with a more rapid onset. But their benefit in long-term outcome can't be discounted, and they shouldn't be ignored simply because they don't have an immediate action. Some patients may have already self-administered epi. This should be considered if further epi is being given. But at least one study has demonstrated that more than 35% of anaphylactic cases required more than one dose of epi. So self-administration really is not considered definitive treatment. When you take a really good history on patients, you can sometimes find out what the trigger was. Known patient allergies are especially important in cases of suspected anaphylaxis. Common allergens are latex, drugs, food, nuts, and seafood being the most common sources, and insect stings, most often from the Hymenoptera family. Food's the most common source among these. 4% of Americans are afflicted with some sort of food allergy, which causes approximately 30,000 anaphylactic reactions and 150 to 200 deaths each year. Penicillin is the most common drug allergy, occurring at a rate of 1 to 5 reactions per 10,000 treatments, with 1 death per 50 to 100,000 treatments. Take care to avoid contact with allergens that trigger these responses as best prevention. A lot of public health efforts have been mounted to help consumers avoid exposure to common allergens. Many airlines no longer routinely serve products containing nuts. Many food items now have stamped on their packaging, whether they're produced in factories or shops that also process nut products. Angioedema presents a particular manifestation of immediate hypersensitivity. It can occur in conjunction with an allergic reaction, or may appear as the sole manifestation of a hypersensitivity reaction. It's similar to urticaria, and both of them usually are considered similar processes on an allergic reaction, but angioedema involves deeper tissue and usually is not as itchy. And sometimes it's confined to the face, the mouth, the lips, and the tongue. Sometimes it appears in the extremities, and in men, the genitalia. Angioedema can occur in patients who take ACE inhibitors. It's managed in the pre-hospital area in the same way as other type 1 hypersensitivity reactions. In some cases, other mechanisms can cause it, the most well-known being hereditary source. Hereditary angioedema is known for its poor response to typical allergic medications. And although they're still indicated, you really have to be vigilant with airway management in the most critical of these cases. Now, an anaphylactoid reaction, it mimics anaphylaxis, including the release of those different mediators from mast cells and basophils, but it's not mediated by IgE antibodies. So, prior sensitization isn't required. These types of reactions, unfortunately, can't be differentiated in the field, so treatment is the same as that for a true anaphylactic reaction. A type 2 reaction is what they call a cytotoxic hypersensitivity. This occurs when a particular cell membrane triggers IgG or IgM antibodies that are directed against it. The complement cascades initiated, a membrane attack complex is generated, and the cell membrane is destroyed or damaged. Complement initiation also attracts phagocytes that release enzymes, further damaging the cell membrane. Now, the type 3 reactions are immune complex hypersensitivity. They appear when an antigen-antibody complex isn't promptly removed by the body system. If they're not appropriately removed, they end up depositing in tissue and they cause an inflammatory response. Whenever they're deposited, the complement cascade is activated and it causes results that are similar to this cytotoxic hypersensitivity. Serum sickness is the classic historic type 3 hypersensitivity disorder. It's been seen when foreign serum is injected, and if it's cleared slowly, it's bound with antibodies to form immune complexes. Now, this is more often seen with certain drugs like penicillin, because foreign serum is rarely used in modern medicine. And type 4 is what they call delayed hypersensitivity. Unlike the other disorders, delayed hypersensitivity isn't caused by antibodies, but rather CD4 lymphocytes, such as those that are targeted by HIV. It's delayed because the time frame for lymphocytic response is hours to days after contact with the antigen. Contact dermatitis can be caused by delayed hypersensitivity. It's the mechanism, for example, of allergic responses to poison ivy, chemical skin allergies, and skin allergies to some cosmetics and soaps. This is also the mechanism used by the tuberculin skin test. Purified protein derivative, or tuberculin, is interjected intradermally with no initial reaction. Gradually, some local reaction may occur, with the degree of the reaction indicating whether they've been infected in the past or if they've just been exposed. Let's see, a more pronounced reaction indicates that the patient has had a prior sensitization to it. Now, signs and symptoms of a generalized allergic reaction can include conjunctivitis, rhinitis, angioedema, urticaria, and contact dermatitis. Respiratory symptoms can range from sneezing and coughing to complete airway obstruction from laryngeal and epiglottic edema, lower airway bronchospasm, and hypersecretion of mucus. And these symptoms can develop very quickly. This is a young lady with angioedema. There's another lady with angioedema. That would be a little tough to intubate, I think. Cardiovascular effects can range from mild hypotension to profound shock. Dysrhythmias may be related, or may be present and related to severe hypoxia and hypertension, and a patient may complain of chest pain if myocardial ischemia is present. Symptoms in the GI system are a result of increased GI activity related to smooth muscle contraction, increased mucus production, and the outpouring of fluid from the gut wall into the intestines that are initiated by these chemical mediators. It can include nausea, projectile vomiting, and uncontrollable diarrhea. Nervous system, they are a result of the sympathetic response due to hypoxia and hypertension. The patient may be agitated, confused, weak, experience seizures, and coma. The most visible signs that distinguish anaphylaxis from other conditions are cutaneous. The signs are usually the result of histamine-induced vasodilation. The patient complains of warmth, dizziness, diffuse redness. They may have hives, urticaria wheals, anywhere from 1 to 6 centimeters in diameter, swelling of the face, the neck, the tongue, and angioedema. These are some hives on a baby. The treatment, initial care is directed at supporting failing vital function. Drug therapy should be initiated as quickly as possible upon recognition of anaphylaxis. Meaning, if your patient is covered with hives and itching and can't breathe, it's probably not the time to try and get a history. It's probably the time to get some epi on board. Evaluate the patient for signs of respiratory and airway compromise. Intubate if necessary. Med control may even recommend a surgical airway if intubation is not a viable option. Get a history if possible. Ascertain if they've self-medicated with an EpiPen, an oral histamine, or an oral antihistamine or a metered-dose inhaler. Administer high concentration O2 and administer Epi to all patients with clinical signs of shock, IM, IV, or via EpiPen. Initiate an IV of normal saline, rapidly infused 1 to 2 liters per protocol if they don't respond to medication and their blood pressure stays low. And other possible medications could be antihistamines, corticosteroids, vasopressors, beta agonists, mag sulfate, and bronchodilators. Immune system disorders. This lupus, okay, systemic lupus erythematosus, it's an autoimmune disease that attacks multiple body systems. It occurs at the rate of about 17 to 48 cases per 100,000 people in North America and Northern Europe, and it's seen most commonly in black women of childbearing age, usually one case per about 250. The problem is there's a failure in a production of B cells that produce abnormal autoantibodies. Okay. In other cases, the antibodies can bind to tissue, causing hypersensitivity reaction. According to the American College of Rheumatology, patients must have 4 of 11 conditions associated with systemic lupus to be diagnosed with that condition. The classic presentation is fever, joint pain, and a butterfly rash in a female of childbearing age. But more serious manifestations can be present, including life-threatening failure of the kidneys and the central nervous system, cardiac problems, including pericarditis, endocarditis, and myocarditis. Aspirin and NSAIDs are useful for pain control, but NSAIDs should be withheld if the patient is having any kidney problems. This is a really complex condition, and families and patients may need to be educated regarding the wide range of systems that can be caused by it and about the autoimmune source of the condition. Okay, let's see. Butterfly-shaped rash on the face that covers the cheeks and the bridge of the nose, skin lesions that appear to worsen on sun exposure, and fingers and toes that turn white or blue when they're exposed to cold or during stressful periods. It's called Raynaud syndrome. Shortness of breath, chest pain, dry eyes, headache, confusion, and memory loss. This is the butterfly rash. That's a definitive diagnostic sign for lupus. The most common cause of death from lupus is opportunistic infection from immunosuppressive type medications that are used to control the disease. Patients who have involvement with the major organ systems like respiratory, nervous, and kidney involvement have much shorter lifespans. Nearly 2 million Americans have lupus, according to the Lupus Foundation of America, with about 16,000 newly diagnosed each year. Anyone of any age can acquire the disease, although 90% of lupus patients are women between the ages of 15 and 45. The scleroderma is newer and more preferred term for progressive systemic sclerosis is the newer and more preferred term for scleroderma. But this is an autoimmune disease that appears as a severe and progressive disease of the skin, and it's often associated with organ complications. It's not a single disease, but rather a group of diseases complicated by abnormal growth of connective tissue which supports the skin and the internal organs. There are 2 main types, localized and generalized. Localized scleroderma primarily affects the skin, and it's further divided into morphea, which is hard oval patches on the skin, and linear, which is a distinct line of thickened and abnormally colored skin, often affecting the arms, the legs, or the forehead. Systemic sclerosis is divided into limited scleroderma, which is a gradual onset and restricted to certain areas of the body, which can eventually lead to problems with the internal organs, and diffuse scleroderma, which is a sudden onset, thickening covers larger areas, and it can immediately affect internal organs. People who have this systemic sclerosis have symptoms which fit into characteristic patterns referred to as CREST, which is calcinosis, which is calcium deposits in connective tissue, Raynaud syndrome. The small blood vessels to the fingers, the toes, the nose, and the ears constrict in response to cold or anxiety. Esophageal dysfunction. The muscle in the lower part of the esophagus doesn't function well, leads to esophageal reflux disease, and esophageal erosion and damage. They have sclerodactyly, which is thick, tight, shiny skin on their fingers and toes, and telangiectasis, which is small red spots on their hands and their feet. The earliest symptoms of progressive systemic sclerosis is Raynaud's. Okay. Poor color, pain, and paresthesias of the fingers consistent with poor blood flow. That's followed by edema and thickening of the skin, including tightening of the facial skin that can result in what they call a stone face. Okay, it's hard for them to smile or do any facial expressions. That's caused by excessive deposits of collagen in the skin. That collagen deposition can spread to the internal organs, causing pulmonary, renal, cardiac, vascular, and GI complications. The pulmonary system, of course, is really important because it's implicated in 2/3 of patients with progressive systemic sclerosis and is the leading cause of death. Common pulmonary symptoms include dyspnea with exertion, non-productive cough, cardiac abnormalities including dysrhythmias, conduction blocks, pericarditis, and heart failure. Estimates of the number of people that have progressive systemic sclerosis range from 40,000 to 165,000. Okay? Raynaud's syndrome can be seen without progressive systemic sclerosis and can be very uncomfortable for patients. But connective tissue disorders can be things like rheumatoid arthritis. The term overlap syndrome or mixed connective tissue disease is used to describe patients who have signs and symptoms of multiple connective tissue diseases. Patients who smoke. Smoking greatly exacerbates these symptoms. Patients should be educated about the importance of preventative measures. For example, flu and pneumonia vaccinations have been really important in those patients who have pulmonary manifestations of progressive systemic sclerosis. Because so many of the organ systems are involved, patients with this condition often have a lot of different specialists involved in their care. Calcium channel blockers are sometimes used to reduce Raynaud's phenomenon. Various cardiac meds can be used if their heart activity is restricted. Various lotions and creams can be used on their skin. A comprehensive physical exam is really required to identify new problems associated with the disease. There is no drug that they can use to stop the thickening of the skin. This is what Raynaud's syndrome looks like. Okay, fingertips are blue, and then there's the variable circulation. And this is sclerodactyly. Okay, the skin is tight, movement of the fingers is restricted. It limits their making a fist and even finger extension. Now, some of the other autoimmune disorders is type 1 diabetes, okay, which is insulin dependent. Autoantibodies against pancreatic islet cells are the usual cause of that kind of diabetes, making it an autoimmune disorder. Okay, we'll discuss this in the endocrine section. Rheumatoid arthritis most commonly develops in women between the ages of 30 and 50. Their joints are destroyed by granulation tissue. Hypersensitivity reactions, such as complexes of antigen and antibody that deposit directly into the joint, can cause extensive damage. Rheumatoid factor and antibodies is positive in 85% of patients with rheumatoid arthritis. An important thing in the pre-hospital management of patients with it is the knowledge that chronic rheumatoid arthritis can degrade the ligament that binds the C2 to C1 in the cervical spine. Because of that, you have to be very careful when you intubate patients with a long-standing history of rheumatoid arthritis. There are a number of kinds of medications that are being used to control it. Pre-hospital care is primarily supportive and should focus on pain relief. Another type of immune system disorder is it's called celiac disease, also known as gluten-sensitive enteropathy or non-tropical sprue. It's characterized by generalized difficulty in absorbing food, which resolves when gluten-containing foods are withdrawn from the diet. This is believed to be caused, at least in part, by the inappropriate action of B and T cells stimulated by gluten. Celiac sprue occurs in approximately 1 in every 3,000 people in the United States. The highest prevalence is in Western Europeans, where the rates can be as high as 1 in 250 to 300 people. Another autoimmune disorder is chronic acute hepatitis and chronic persistent hepatitis. They're often categorized as autoimmune conditions. Multiple sclerosis, which we cover in the neurology section a little bit later on. But that's an inflammatory disorder that affects the CNS and is believed to be autoimmune in nature. It's present in 0.1% of the U.S. population, with the most common age of onset being 25 to 30 years of age. It's twice as common in women compared to men. And although the exact mechanism isn't known, a leading theory suggests that a genetic predisposition interacts with an environmental trigger or an infection to produce T cells oriented to attack the central nervous system. It causes areas of scarring or plaques that result from destruction of the myelin sheath, leading to demyelination. Another one is Crohn's disease, which is also discussed later on in the program. It's chronic inflammatory bowel disease. The exact cause of it is unknown, but environmental, inflammatory, immunologic, and even genetic factors are thought to be involved. Whether this disease has an autoimmune complement is a subject of great debate. The thought is that the disorder occurs as a result of an overreaction of the immune system to one of these agents rather than an autoimmune disorder.